Hey guys, this is Joe Weatherly. I'm a PGY2 family medicine resident, and I want to talk a little bit about PPI use. We're going to question the current use. Some of the new research that's been come out will help us question that and maybe put us in a better light for using it more appropriately in the future. So the known risks of PPI use, pretty well documented through several mostly inpatient studies, people associated with, or people on ventilation, or people in an ICU setting, and that does make it difficult to extrapolate the results onto your basic floor patient or in an outpatient setting, but we know that it can be associated with an increased risk of strep pneumonia, C. difficile infections, bacteremia, and other infections. We know that Alimentary and Pharmacology and Therapeutics publication in 2012 November cited several increased or risk of serious infection, especially in decompensated cirrhotic patients. So that's different than an H2 receptor antagonist. It's only in PPIs, and that's mainly like infections causing spontaneous bacterial peritonitis. So your end-stage liver failure patients, you may want to question your use of a PPI in them in an inpatient or outpatient setting. We also know that through Archives of Internal Medicine in 2011, they published results from a study in June that they showed an increased risk of hip, wrist, and spine fracture, and that's patients that were on alendronate. So we were looking to prevent fractures, and PPIs apparently cause loss of effective alendronate. More research needs to be done to show direct causality, but there's definitely a correlation there. So definitely question your use of PPIs in people on alendronate or people with osteoporosis and increased risk of hip, wrist, or spine fractures. We also know that you should check a magnesium. PPIs have been shown to lower serum magnesium slightly when used with diuretics typically. Kidney International in 2013 put out a publication trying to make people aware of that, as well as the results of a small study. Showed about a 0.012 milligram per deciliter decrease in magnesium with PPI use, and that's above that of just a diuretic in the same fairly well-matched patients. So again, C. diff infection, you have roughly a 2 times greater risk of getting C. diff with antibiotics and PPIs mixed. That comes from the Clinical Journal of Gastroenterology and Hepatology in March 2012. Community-acquired pneumonia, 2 times greater risk, and these are all absolute risk increases. I don't have the exact numbers, but they'll be in the show notes. Also, that came out of the Alimentary Pharmacology and Therapeutics publication in 2012 November issue. We know that there's an increased risk of bacterial overgrowth in the small intestine, shown through a meta-analysis that was published in the Clinical Gastroenterology and Hepatology in 2013 May issue. There's an increased risk of drug hypersensitivity reactions, so you want to consider maybe holding that, or at least reconsidering long-term use of a PPI in a patient that already has that increased drug reaction. Your patient that's allergic to, every non-narcotic pain medication, your patients that are allergic to work in the direction east, do not use PPIs in them because there's a 4% per day increased risk, and that's typically only found in patients that have a previous history. And that also came from the Clinical and Experimental Allergy publication in 2013 March issue. There's a significant amount of drug-to-drug interactions. Those drug-to-drug interactions include oral anticoagulants, warfarin, perhaps some of the novel oral anticoagulants, but yet again, the fire and forget concept behind some of the new oral anticoagulants make it difficult to assess the drug-to-drug interactions because we're not monitoring a level. We can't check for efficacy. We find out when the patient ends up with a clot and or dies, and then we can only guess about why. We did, however, find that that was more common in omeprazole, not pantoprazole. So probably if you have to choose a patient for that already has polypharmacy going on, pantoprazole is your better choice over omeprazole. Again, most of these were population-based trials or studies, meta-analyses, or clustered studies, rather than prospective, well-designed RTCs. They definitely don't have that cause and effect evidence that we would like, but these are the best we have that I could find as of right now. Another thing you got to consider is with that oral anticoagulant interaction, there was a good trial, Cogent trial, and there have been at least one more that's been started since then in Annals of Internal Medicine, documented in 2010, that they had increased risk of GI bleeds when they combine PPI with clopidogrel. And that again was only focused on bleeds, not infection, and it was a retrospective cohort, so it could be a little bit stronger evidence, but definitely got to worry about any patient that has a risk of GI bleed, and you put them on a PPI to stop their ulcer, but if they have other comorbidities, you may need to switch over to something else. And that's we'll be talking about PPIs for GERD and peptic ulcer disease later. But also we've noticed in Alimentary and Pharmacology and Therapeutics 2012, there was an update that stated they showed an increased risk of enterochromaffin-like cell carcinoids. So not just some of these benign interactions, but actual cause of harm. That study was not, again, wasn't powered to show cause and effect, or that as an outcome, but there'll be more research done in the future on things like this, but it's just good to be aware that it's out there. So bottom line, I think you're going to have to question kind of where you've used PPIs in the past. If you've been kind of a traditional life, you prescribe them to people for life. If you use them, remember the FDA drug safety communication that came out in 2011 that recommends a baseline and periodic magnesium level. Again, that was because of that small decrease in magnesium primarily with diuretics, but they're recommending it with all of your patients that are on long-term use. Question your use of a PPI in end-stage liver failure because of a 40% absolute risk increase of infections that led to hospitalization, which is definitely worth noting. That came from a November 2012 publication that'll be in the show notes. Avoid PPIs with NSAIDs. Some of the obvious balance that we would expect with NSAIDs causing ulcers, PPIs preventing ulcers. It's a great combination. Well, not so much. Gastroenterology in 2011 started showing evidence of bacterial overgrowth and dysbiosis made worse with that combination. So maybe shift them over to an H2 receptor antagonist. Again, question your PPI use in the elderly, those people also that are at risk of bone fractures. Question your use of a PPI in those with high risk of C. diff. So fluoroquinolones, multiple antibiotics given in a short time period or over a long period of time even. And then question your use with oral anticoagulants or antiplatelet drugs like clopidogrel and ticagrelor. Those were the two that were mentioned in Circulation 2012, and they showed a 2% absolute risk increase of MI or stroke from the Plato trial when you use with an antiplatelet medication. Question your use with any transplant patient. Again, that's probably not very many of us. We're going to refer most of those out, but just to be aware, in Transplantation 2014, March 15th, they came out with a nice study that showed use of PPIs with some of the anti-transplant medications that are more commonly given showed an 3% increased risk of transplant rejection. So another drug-to-drug interaction. So this may these concepts might lead out to more research, including HIV and other life-sustaining medications. So that's probably something to be aware of in the future. And question your use of a PPI in COPD patients. They're going to get an acute exacerbation, we know already. You don't want to increase that likelihood.